fractures of the vertebral column. Initially, today, the topic for today was fractures of the vertebral column, but we will present today fractures of the pelvis, and tomorrow we will present the fractures of the vertebral column.
I have a question.
Yes,
I was
please.
wondering if it would be okay for us to record a meeting.
Yes, it's okay.
Thank you.
You're welcome. So, a few things about the anatomy of the pelvis. We have a number of bones here. In the back, we have the sacrum with the sacral wings. One moment, please. So in the back, we have the sacrum with these sacral wings, and here we have the sacroiliac joints. We have the iliac wing. Above it, we have the iliac crest. We have a number of spines, two iliac superior spines, two iliac inferior spines. In the front, we have the pubic symphysis and the two bodies of the pubic bones. Here is the foramen obturatum, the ischiatic tuberosity. This is the sacropubic rami, and here we have the iliac pubic rami, the two acetabulums which will form the hip joints. The same thing seen from above. In the back, we have the sacrum with these two sacral wings, the sacroiliac joints. This is the left one, this is the right one. The two iliac wings with the iliac crests, the four spines, the superior one, the inferior one, the superior one, the inferior one. Here in the front, we have the pubic symphysis between the two bodies of the pubis, and here we can see the iliopubic rami. A few things about the vascularization of the pelvis. We have the common iliac artery, which divides in the external one and the internal iliac artery. Above the iliopubic rami, the external iliac artery will continue with the femoral artery, while the internal iliac artery give rise to the superior gluteal artery and the inferior gluteal artery. And here in the front, we have the obturator artery. The same thing. And some more things about the nerves at this level. We have a number of important nerves. In the front, we have the femoral nerve and the obturatory nerve in the front. And in the back, we have this big nerve, which is the sciatic nerve. The fractures of the pelvis can be produced by low energy traumas or high energy traumas. A low energy trauma will result in an isolated fracture of the pelvic bones, while the high energy trauma will lead to a fracture of the pelvic ring. A low energy trauma will lead to a fracture of the iliopubic and or ischiopubic rami, a avulsion fracture of the anterosuperior iliac spines or anteroinferior iliac spines, or a fracture of the ischiatic tuberosity. It can lead to an isolated fracture of the sacrum, or a simple or comminuted fracture of the iliac wing. A high energy trauma can be produced by a car accident, by motorcycle accidents, or when the patient is a pedestrian which is traumatized by an impact with a vehicle. Other high energy traumas are produced by falls from heights, by penetrating mechanism by firearms or blade weapons, or in crushing accidents like in mine accidents, earthquake, avalanches, and so on. There are a number of classifications. We have the anatomical classification, which is based on the lesion site, the anatomopathological classification, which depends on the number of interruptions of the pelvic ring, and we have another classification which is based on the mechanism of the fracture, by anteroposterior compression, by lateral compression, or by vertical shear. The most important classification is the tile classification. We have three types of fractures, A, B, and C, and which...
Excuse me, Professor?
Yes, please.
We haven't been switching the slide.
I'm sorry?
We're still on the nerve slide.
Okay. Sorry. Let's see what happens. Let's try again.
I think it's the same problem as in the first day when you were making the screen full screen. It was freezing. So
okay,
I think it's better.
You can see. What do you see right now?
The tile classification.
The tile classification. And now?
Nothing. It's the same slide.
Okay, so it freezes because I changed it for the next slide, but it doesn't work, I see.
Yeah.
Okay.
So I think it's better to not make it full screen.
Okay. So right now we can see the tile classification.
Yes.
And now the rotational
Yes.
instability. Okay, let's do it this way. So we have the tile classification. In this classification, we have three types of fractures, A, B, and C. And each one of these types is divided in other three types, A1, 2, and 3, B1, 2, 3, and so on. The type A fracture, it's a stable fracture. That means for A1, a fracture of the pelvis which doesn't involve the ring. A2, it's a stable, minimally displaced fracture of the ring, while A3, it's a transverse sacral fracture. The type B fracture, it's a fracture which is rotationally unstable, but vertically stable. And in the next two slides, we will see what means rotationally unstable, what means vertically unstable. And these type B fractures can be B1, which is an open book fracture. That means that in the back, we have a stable pelvis, while the fracture will open the pelvic ring in the front like an open book. A B2 fracture, it's a fracture produced by lateral compression, and all the fractures are ipsilateral, are on the same side, on the left one or on the right one. The B3 is also a fracture produced by lateral compression, but the fractures are contralateral. That means that on the let's say that on the right side we have a fracture of the pelvic ring in the back, and on the right side we have a fracture of the pelvic ring in the front. That means that we have a contralateral fracture, like a bucket handle. The type C fracture, it's a fracture that is rotationally and vertically unstable. And we can have a C1 fracture, which is unilateral rotationally and vertically unstable. That means that all the fractures are on only one side. The C2, it's a bilateral fracture. We have fractures of the pelvic ring on both sides, on the left one and then the right one. And the C3 fracture, it's a fracture which is associated with a fracture of the acetabulum. Let's try to explain what means rotational instability and vertical instability. We have this fracture. In this fracture, we have in the front a dislocation at the level of the pubic symphysis, and this double fracture at the level of the foramen obturatum. We have a fracture of the ilio-pubic rami and also a fracture of the ischio-pubic rami. In the back, we have this fracture at the level of the sacral wing. But in the back, we have the sacroiliac joint, which is untraumatized. That means that this hemipelvis, the right hemipelvis, can rotate this way, but because these ligaments are intact, this hemipelvis cannot go up and down. That means that this fracture is rotational unstable, but it's vertically stable because this sacroiliac joint, which is intact. Another fracture. In this fracture, we have a dislocation of the pubic symphysis in the front, and in the back, we have a fracture of the iliac bone and trauma at the level of the sacroiliac ligaments. This fragment, this left hemipelvis, doesn't have any bond with the rest of the pelvis. That means that this hemipelvis can rotate, and because of that, we have rotational instability, but also this hemipelvis can go up and down. That means vertical instability. So in this case, we have a fracture with vertical and rotational instability. At the clinical examination, at the inspections, we can see hematomas at the level of the ipsilateral flank, at the level of the inguinal region, in the proximal thigh, or in the perineum. The patient can present hematuria or rectal bleeding if we have lesions at the level of the urinary tract or at the level of the rectum. Vaginal bleeding if we have lesions at the level of the vagina. Abnormal positions of the lower limb and the lower limb length discrepancy. If we have lower limb length discrepancy, that means that we have a fracture with vertical instability. One hemipelvis is ascended, and the lower limb on this side can have a false shortening. It's not a real shortening. It's because the whole hemipelvis and the whole lower limb is ascended because we have a vertical unstable fracture. We can palpate the pubic symphysis, the pubic rami, the iliac crest, and the sacroiliac joints. There is a maneuver called the bimanual compression and distraction of the iliac wings, and also abduction and adduction of the hip. It can detect instability, but there is a risk to increase bleeding by the mobilization of the primary clot. So we don't advise these maneuvers. And we can perform also a manual traction of the lower limb in order to detect an eventual vertical instability. The clinical examination means also digital vaginal and rectal examination. If we have a lesion at the level of the urethra, we can have a bladder outlet obstruction. And in any clinical examination, we must also detect the motility and sensibility at the level of the pelvis and lower limbs. And also, we try to detect arterial pulse, temperature, and color of the lower limb teguments in order to early detect an eventual lesion of the great vessels at this level. That means a lesion of the femoral arteries or veins, or lesions of the iliac arteries and veins. We have the imagistical examination, and the first one is the radiological examination. On this antero-posterior X-ray view of the pelvis, we have the right hemipelvis, which is in yellow, and the left hemipelvis, which is in green. In the back, we have the sacrum. These are the sacral wings with the sacroiliac joints, the pelvic ring, the two acetabulums with the femoral heads in it. Here we have in the front the pubic symphysis. These are the bodies of the pubic bones. Here is the ischiatic tuberosity, the right one and the left one. This is the ischiopubic rami. This is the iliopubic rami. This is the iliac wing. And this is the iliac crest. This is a normal X-ray view of the pelvis. The same thing, the right hemipelvis, the sacrum in the back with the sacral wing, the sacroiliac joint, the iliac crest, the iliac wing, the antero-superior iliac spine, the antero-inferior iliac spine. This is the acetabulum, the femoral head, the femoral neck, the proximal part of the femur with the greater trochanter, the lesser trochanter, pubic symphysis, the body of the pubic bone, the iliac pubic rami, and the ischiopubic rami. Okay, let's see some X-ray views with fracture. We have an antero-posterior X-ray view of the pelvis, and we have a number of fracture here. We have here a fracture of the ischiopubic rami, and here another fracture of the iliopubic rami. It's a fracture in the front part of the pelvic ring. The pelvic ring is complete, it's intact in the back. That means that we have a stable fracture of the pelvic ring. This is the right part of the pelvis, while the left part is intact without any fractures. Another image, we have a fracture at the level of the acetabulum, and we have here a fracture of the ischiopubic rami. Another one, we have diastasis, that means widened joint at the level of the pubic symphysis. and a widened sacroiliac joint on the right part. That means that we have a lesion of the pelvic ring with this pelvic ring which have vertical and rotational instability, because we don't have any bones between this hemipelvis and the rest of the pelvic ring. And this hemipelvis can rotate, but it can also go up and down. An avulsion fracture of the anterosuperior iliac spine. We have this fragment at this level. Of course, that this is a stable fracture. It's a fracture which was produced by a low energy trauma of the pelvis. Another image with lesion at the level of the sacroiliac joint, of the left sacroiliac joint, and another lesion, another dislocation at the level of the pubic symphysis. The whole left hemipelvis is ascended. That means that we have vertical and rotational instability, and the patient will present a false lower limb discrepancy by false shortening of the left lower limb. The length of the left lower limb is the normal one, but the whole hemipelvis with the whole lower limb is ascended, and it will appear to be shortened. We have a number of specific radiological incidences for fractures of the pelvis. We have this inlet view of the pelvis in which the patient is supine on the examination table, and the X-ray view will make 45 degrees with the horizontal line. In this incidence, we can see very well the whole pelvic ring. In the outlet view of the pelvis, the patient is also supine on the examination table, but the X-ray view will make 45 degrees with the horizontal line coming from the distal part of the body. In this incidence, we can see very well the foramen obturatum, the pubic symphysis, the iliopubic rami, and the ischiopubic rami. So this incidence is for the pelvic ring. This second incidence is for the foramen obturatum and the ischio and iliopubic rami. In the obturatory incidence, the patient is supine on the examination table, and it will make it is positioned in order to form a 45 degrees with the horizontal line. And in this obturatory incidence, as we can see from the title, we can see very well the region of the foramen obturatum. In the other incidence, the patient is positioned at 45 degrees with the horizontal line in the other direction, and we can see very well the iliac wing. Ala means wing in Latin. So this Alar incidence is performed in order to see the iliac wing. Here we have an incidence which is an Alar incident on the right hemipelvis, and of course it is an obturatory incidence on the left hemipelvis. And we can see a fracture of the ischiopubic rami here, a comminuted fracture of the iliopubic rami with a fracture of the acetabulum, a fracture at the level of the ilion body, and another fracture at the level of the iliac wing. So a comminuted fracture of the left hemipelvis. The CT scan can give us a three-dimensional reconstruction of the pelvis, like the image on the left side, this one. And here we can see this fracture at the level of the right sacral wing, a fracture at the level of the left iliopubic rami, and another fracture at the level of the left ischiopubic rami. Here we have other images from the CT scan. These are horizontal slices of the pelvis. Here we have a fracture of the right sacral wing. Here we have a fracture of the left iliac wing. The MRI is very useful in order to detect lesions of the soft tissues and of the organs, but it can provide us also informations about some fractures which are not visible on X-ray. And here we have an example. This is patient with normal X-ray view. It has pain at the level of the inguinal region, and when we perform an MRI of the pelvis, here we can see an undisplaced fracture of the left ischiopubic rami. So the CT scan is for bones, MRI usually is for soft tissues and organs, but it can provide us also informations about some fractures which were not detected at the normal X-ray view examination. Complications can be hemorrhage, which is the most dangerous complication, and the source of this hemorrhage can be the fracture site or lesions of the big vessels at this level. And in order to diagnose these lesions, we can perform an arteriography or an CT scan with contrast substance, and the treatment will consist in laparotomy and hemostasis. In some cases, we can perform embolization by arteriography, and of course, external fixation of the fracture. Because if we don't fix the fracture, the movement of the bone fragments can produce other lesions of the great vessels, but also the mobilization of the bones will mobilize the clot and will provoke a secondary hemorrhage. So the treatment means hemostasis, but also fixation of the fracture. Other associated lesions are lesions of the bladder, of the urethra, of the genitals at this level, vagina and uterus, and lesions also of the rectum. If we have a lesion of the rectum, an iliac anus in emergency must be performed in order to redirect feces from the lesions. Is the so-called diverting colostomy, because feces and a fracture means many complications, osteitis, osteomyelitis, and so on. The open fractures are rare at this level because the bones of the pelvis are well covered in fat and muscles. These open fractures can be open inside an organ, in the rectum, in the vagina, or in the bladder, or we can have the normal open fracture, which is open in the exterior at the level of the iliac wing or at the level of the perineum. The treatment means stop the hemorrhage, debridement and closure of the wound if possible, iliac anus if necessary, the diverting colostomy, and stabilization, fixation of the fractures. The treatment. The traction is used only as temporary immobilization because if we maintain this traction as definitive method of immobilization, that leads to many complications. Thromboembolization, lesions of the teguments, urinary infections, and so on. So all the complications of the bed immobilization. Also, in emergency, we can use the pneumatic splints. Then this will act as a cast, and it will immobilize the pelvis and the lower limbs. And it will also prevent shock because it will compress the lower limbs and it will redirect the blood from the lower limbs towards the trunk, where this blood is very useful in order to maintain the vascularization of the heart, lungs, and internal organs. The pelvic hammock is indicated in the open book fractures, and the patient is placed in a canvas sling or a hammock. This is the hammock. And this hammock is suspended by a tension spring to an overhead framing bar. We have here the framing bar. And the pelvis is suspended so that is just off the mattress. That means that between the pelvis of the patient and the mattress, we have 2 or 3 centimeters. The body weight forces is converted in lateral compression, and this lateral compression will close the open book fracture. And the patient will stay in this pelvic hammock for 2 or 3 weeks till we have primary fixation of the fracture. The external fixation, it's a good method of fixation in emergency. It will control the hemorrhage because we immobilize the bone fragments. In some cases, it can be maintained as definitive treatment. We have here an example. This is the external fixator with the rods in the pelvic bones. These are the connectors, and here we have carbon fiber rods. There are some problems with the external fixation. In the obese patient, it's difficult to mount an external fixator because of the belly. In time, infections at the pins level can appear. And the main problem is that this external fixator will not stabilize the posterior complex. If this posterior complex, the posterior part of the pelvic ring, is injured, that means that it will require traction or posterior osteosynthesis. And we have these 2 images with external fixators, so the rods, the connectors, and the bars, but we have also 2 screws in the back in order to fix the posterior complex, a fracture at this level of the iliac wing. So here we have a combination, an external fixator with posterior fixations by screws. Here we have a total hip arthroplasty, an uncemented hip prosthesis. and here we proximal femoral nail for a fracture at the level of the proximal femur. Other examples with external fixators, these external fixators are composed by pins, the connecting rods, and clamps or connectors between them. Another method of osteosynthesis is the internal fixation. We can perform mini-invasive sacroiliac fixations with screws under C-arm control. Here we have an image with an C-arm device in the operating room, and through some minimal approaches, we can introduce screws at the level of the posterior pelvic ring in order to fix fracture at this level. Another method is open anterior fixation with plates and screws at the level of the sacroiliac joints. So here we had a dislocation of the sacroiliac joints, and this is the postoperative image after reduction and osteosynthesis with 2 plates and screws. Osteosynthesis of the pubic symphysis can be performed with plates. Here we have a diastasis, a dislocation of the pubic symphysis. This is the preoperative image, and in the postoperative image, we can see a reduction and osteosynthesis with a plate at the level of the pubic symphysis. If we have fractures of the acetabulum and fractures of the iliac wing, the treatment consists in reduction and osteosynthesis with plates. Some fractures of the iliopubic and ischiopubic rami can be also treated by reduction and osteosynthesis with plates. If we have fractures of the sacrum, these fractures can be fixed by screws and or plates. Here we have a sole plate, while here we have a plate, another plate, and a number of screws. In this other image, we have 2 screws in the back, and we have a plate at the level of the pubic symphysis. So, in order to summarize, from the back of the pelvic ring towards the front of the pelvic ring, for the fractures of the sacrum, we can use screws and or plates. For the sacroiliac joint, screws and or plates. For the iliac wing, nothing if we have an isolated fracture of the plate, or if we have a number of fractures, we can use a plate with screws. If we have a fracture of the pubic rami, nothing if the fracture is isolated. If the fracture is associated with other fractures that will lead to fracture which is unstable, we can use plates and screws for this fracture. If we have a dislocation of the pubic symphysis, we can use a plate if this displacement is a great one, or if it is associated with other fracture. But this dislocation can be treated orthopedically if it is isolated or if it has a minimal displacement. The complications. Infections in around 25% of the cases, thrombosis and thromboembolism, malunion of the fracture that will lead to gait, lower limb discrepancies, and the osteoarthritis of the hip, of the knee, and of the vertebral column, and in some cases non-union. These were the fractures of the pelvic ring. The second topic for today is the fractures of the acetabulum. The acetabulum is supported by two columns in the shape of an inverted I. This is the anterior column. Sorry. This is the anterior column, and this is the posterior column. We have the ilium with the iliac wing, the iliac crest. This is the acetabulum, the foramen obturatum, the ischion with the tuberosic, with the ischiatic tuberosity, the pubis in the front with the iliopubic rami and with the ischiopubic rami. So, for the acetabulum, we have the roof of the acetabulum, the anterior column in the front, the posterior column in the back. The usual mechanism for the fractures of the acetabulum is produced by the femoral head, which strikes the acetabular wall. Usually in car accidents, when the dashboard strikes the knee, and the femoral head will strike the posterior wall of the acetabulum. The fracture location will depend on the position of the lower limb at the moment of the trauma. If the lower limb is in flexion, extension, abduction, adduction, internal or external rotation. Here we have an example. This is the driver. The dashboard will strike here in the knee. If the patient is with the hip in some extension, the femoral head will strike the posterior wall of the acetabulum in its upper part, and we will have a fracture here at the level of the upper part of the posterior wall. If the hip is at 90 degrees, the femoral head will strike the posterior wall right in the middle, and we will have a fracture of the posterior wall in its medium part. If the patient is with the hip flexed, the femoral head will strike the posterior wall of the acetabulum in its inferior part, and we will have a fracture of the lower part of the posterior wall. The main causes of the fractures of the acetabulum are car accidents, sport accidents, and falls on the hip. We have two columns, the anterior column, which is here in blue, and the posterior column, which is in brown. The anterior, or the iliopubic column, is composed of the entire pubis and the large portion of the ilium. The posterior column, the brown one, or the ilioischial column, is composed mainly of the ischium and the small part of the ilium. The anatomical classification of the fracture of the acetabulum is based on the two columns and the two walls of the acetabulum. We have the anterior and posterior column and the anterior and posterior walls of the acetabulum. We can have a number of types of fracture. A transversal fracture of the acetabulum with two fragments, a T fracture with a vertical line and a horizontal line, and that means three main fragments, a transversal fracture with one wall, a T fracture with one wall, and a T fracture with floating acetabulum. and a number of schemas with example. This is a fracture of the anterior column. We have a longer fracture line and bigger fragments. In a fracture of the anterior wall, we have shorter fracture line and smaller fragments. This is a fracture of posterior column, long line of fracture, big fragments. This is a fracture of the posterior wall, smaller fractures, smaller fragments. These fractures of the posterior wall are the commonest type. That means around 1/4 to 1/3 of all fractures of the acetabulum. This is a transversal fracture of the acetabulum. The T-type fracture with a horizontal line fracture and a vertical one. A transverse fracture associated with a fracture of the posterior wall, posterior column and posterior wall. And here we have a fracture of both columns. The anterior column is fractured, but also the posterior column. At the clinical examination, first we must identify the type of mechanism. If we have a low or high energy trauma, we can inspect the position of the lower limb at the moment of the trauma and the direction of the impact. We can find traumatic marks at the level of the pelvis and at the level of the lower limbs, and also we can see hematomas. Abnormal position of the lower limb, which can be ascended and shortened with lower limb length discrepancy. And we can detect also associated lesions like fractures of the patella, fractures of the femur, knee sprains, and so on. Because if we have a high trauma impact, that means that not only the acetabulum will be traumatized, but also other structures. We must inspect the reflexes and the motory and sensibility at the level of the sciatic and femoral nerves, and we must detect the arterial pulse at the level of the lower limbs, and we must inspect the aspect and then temperature of the lower limb in order to early detect lesion of the great vessels at this level. At the radiological examination, there are a number of landmarks at the level of the acetabulum. We have the iliopectineal line, the ilioischiatic line, the teardrop, which is also called the radiological U, the dome, which is the acetabular ceiling or roof, the anterior acetabular lip, and the posterior acetabular lip. They are here represented in a schema, but we will see on the radiological images. This is the iliopectineal line in blue. And if we have a fracture of the anterior column, this iliopectineal line will be interrupted. The ilioischial line is represented here in red. And if we have a fracture of the posterior column, this ilioischial line will be interrupted. The anterior lip of the acetabulum, here in green, will be interrupted if we have a fracture of the anterior wall. Here is the radiological U or the teardrop. The posterior lip which is here in magenta, will be interrupted if we have a fracture of the posterior wall of the acetabulum. And here the dome in blue, it will be interrupted if we have a fracture of the acetabular roof. Another example, here we have the iliopectineal line. It's a normal pelvis here. This is the ilioischial line. Here we have the radiological U, or the teardrop. This is the posterior wall. This is the anterior wall of the acetabulum. We can also use the same radiological views as for the pelvis, the obturatory and alar views of the pelvis. In the obturatory incidence, we can see very well the iliopubic column and the posterior wall of the acetabulum, while in the alar incidence of the hemipelvis, we can see very well the posterior column and the anterior wall of the acetabulum. We can use the CT scan in order to detect all the fractures line, the dimensions of the fragments, their displacement, and so on. And here we have a horizontal slice in a CT scan of the pelvis, and we can see here fracture of the anterior wall of the acetabulum. Shorter fracture line and smaller fragments. Here we have a fracture of the posterior wall, short fracture, small fragments, while in this fracture of the posterior column, we can see longer fracture lines and bigger fragments. Three consecutive slices, three consecutive horizontal slices at the level of the acetabulum and of the iliac wing, we can see a fracture that starts in the iliac crest and go down till the acetabulum, and here it's a fracture of the anterior column of the acetabulum. Bigger fragments, longer fracture line. A three-dimensional reconstructions of the pelvis with a transverse fracture of the acetabulum associated with a fracture of the posterior wall. This is the transversal line. And here in the back, we can see a comminuted fracture of the posterior wall. The same thing here. Here is the transversal fracture. And here we have the comminuted fracture in the posterior part of the acetabulum. The aim of the treatment is to obtain hip stability and congruency, and our ideal will be to obtain an anatomical reduction of the articular surfaces and a stable fixation. According to Tile, there are a number of steps in order to correctly treat a fracture of the polytraumatized patient. First, early on concomitant assessment and resuscitation. We must establish adequate ventilation in order to maintain the circulation. Reduction of the hip dislocation in emergency. That means in the first 6 to 12 hours after trauma. and reduction and osteosynthesis of the acetabular fracture, which is delayed emergence. Delayed emergency means that it must be treated as soon as possible. There are a number of exceptions, and the indications for emergency surgical treatment for a fracture of the acetabulum are an irreducible hip dislocation. That means that we cannot obtain reduction of the dislocation by external orthopedic maneuvers. An unstable hip reduction, that means that we obtain the reduction, but when we mobilize the hip, the dislocation will reproduce. Associated severe neurological lesions like the paralysis of the sciatic nerve or aggravation of the neurological deficit after reduction. And in this case, our aim is to treat also the neurological lesion, the lesion of the sciatic nerve or of the femoral nerve. Another indication for emergency surgical treatment is an associated vascular lesion or the presence of an open fracture of the pelvis. An open fracture must be treated in the first 6 hours after trauma. An irreducible hip dislocation means that we have some intra-articular fragments which block the reduction. And unstable hip reduction means that we have big fragments from the columns or a comminuted fracture of the quadrilateral surface. That means medial instability and a dislocation of the femoral head inside the pelvis. The treatment of acetabular fracture is based on the general status of the patient, the age of the patient, the bone quality, the type of the fracture, and the surgeon's experience. This treatment must be performed in the first 7 days after trauma. The treatment consists in reduction and osteosynthesis with screws and or plate. We have here an example with a neutralization plate which will protect the leg screws from bending, shear, and rotation. We have here a fracture of the posterior wall, which was treated by reduction and osteosynthesis with plates and screws. Another example, here we have the preoperative three-dimensional reconstruction on a CT scan, and we can see a fracture of the posterior wall at this level, and these are the postoperative images after reduction and osteosynthesis with a long plate and screws. A fracture of the posterior column after reduction and osteosynthesis with 2 plates and screws. Osteosynthesis with plates can be performed for fractures of the anterior wall or of the anterior column. Osteosynthesis with screws are indicated in fractures of the anterior column or of in the anterior wall when we have a small number of fragments and big fragments. Another example with fractures of both acetabular columns after reduction and osteosynthesis with plates and screws. If we have impacted fragments after a fracture of the acetabulum, we must elevate the impacted fragments, and after that we have here a restant cavity, We cannot leave this empty cavity. This must be filled with something, and this something is cancellous autograft, which is harvested at the level of the iliac crest, or this empty cavity must can be filled also with bone substitute. As I said, our aim is to obtain an anatomical reduction of the articular surfaces in order to prevent osteoarthritis in time. Complications. The most common complication is hip osteoarthritis, shock as an early complication, a vascular necrosis of the femoral head if we had a dislocation of the hip, infections, thrombosis and thromboembolism, malunion, and in some cases necrosis of soft tissues flaps in extended approaches for surgical treatment. Other complications are lesions of the nerves, the sciatic, femoral, gluteus pudendum, or cutaneous femoris lateralis nerves, and lesions of the femoral arteries and veins, or of the iliac arteries and veins. Thank you for your attention. Any questions, please?